Good evening, and welcome to our Columbia Children's Health webinar. Tonight, we will be focusing on emerging and re-emerging infectious diseases in children and adolescents and talking about what's new and new again in 2022. My name's Jennifer Ratner. I'll be your moderator. I'm a pediatrician and the Director of External Affairs here at Columbia Children's Health. I want to welcome our audience of pediatricians and pediatric healthcare providers tonight. And I want to welcome our really terrific panel of Columbia Pediatric Infectious Disease experts. Our experts include Doctors Lisa Saiman, who, in addition to her role as a pediatric infectious disease specialist, is also the hospital epidemiologist at our hospital, New York-Presbyterian Morgan Stanley Children's Hospital. I'd also like to welcome Dr. Natalie Neu, Dr. Candace or CC Johnson, and Dr. Jason Zucker, who, in addition to being a pediatric infectious disease specialist, is also a member of our Department of Medicine and is an adult infectious disease specialist as well. Before we get started with the discussion, I'd like to refer to a little bit of housekeeping. And just to remind you that the chat will be disabled during this discussion, but the Q&A will be open, and we welcome and encourage your questions as we go through, and we'll try to get to all of them during the webinar. And if you need to leave early or would like to refer colleagues to this webinar, this will be up on our Columbia Children's Health YouTube channel starting tomorrow. Just a brief disclaimer that the content provided on this webinar, regardless of the date, should never be used as a substitute for direct medical advice from whoever's watching this, their own physician or a qualified clinician. And with that housekeeping and a reminder to follow us on social media, follow Kids at Columbia, I would like to begin by just letting us have an excellent discussion tonight, which I anticipate it will be. So for the pediatricians and healthcare providers out there, your offices, our hospital, and indeed the news, when you turn on the news, is basically flooded with reports or with actual children with respiratory diseases right now. Coughing, fevers, wheezing, and sometimes worse, as the infectious disease people used to say, too numerous to count, or TNTC. And I think it's, we've all heard about the triple-demic, and I would like to now unpack all of this with the experts and start with Dr. Saiman, perhaps, to talk about, as the epidemiologist, what is causing this surge? What are we seeing in the hospital? What viruses? And I give it to Dr. Saiman.
Thank you, Jennifer, and welcome to all of the people in the audience. I'm going to start off with talking about what is being called the immunity gap. There was a really nice description of this in the Lancet recently. And this is what we think has happened. We'll talk about RSV, which we are seeing absolutely sky-high rates in children. And usually, as the audience knows, it's predominantly something that everybody sees in their first 2 years of life. It's a ubiquitous virus and everyone's infected. But what we're seeing now in the hospital is, in addition to these very young infants getting admitted, we're seeing older children getting admitted with RSV. So you know that this is the tip of the iceberg of the spectrum of illness, where these children are really seriously ill, some of whom, of course, have underlying comorbidities, but not all. And so what this immunity gap refers to, if we use RSV as a very prime example, is that despite the fact that everyone is infected during their first 2 years of life, they're infected over and over again. And what we think, because of lockdown and because daycares were closed and schools were closed, that a whole cohort of children missed RSV during what would have been, let's say, in the 1920, 2021, 21-22 respiratory viral seasons, they didn't see RSV, or they didn't see as much RSV. So, and in addition, there's also a hypothesis that pregnant women who ordinarily could see RSV and then get antibody boost and transfer those antibodies to their babies and protect their babies were not seeing RSV. And then the school-age children that often bring RSV home to the households were similarly not seeing RSV during most of the pandemic. So we just have this enormous, highly susceptible patient population. And again, in our hospital, we are seeing the tip of the iceberg of the more severely ill children, and it's just a numbers game. And it's happening all over the United States. This is not something that is limited to the New York metropolitan area or even the Northeast. You know, there's no prediction how long this is going to last, unfortunately, Jennifer. So, you know, we know that our team members in the emergency room now are really absolute heroes coping with this. Similarly, we are really worried about influenza. So this is just a tremendous reminder to everybody to get their own flu vaccinations, make sure their patients are getting their influenza vaccinations. We are having an early influenza season. It's nothing near the numbers that we're seeing for RSV, but it's definitely higher than we've seen in many, many years. So far, at least in our institution, because we can type the influenza, it's mostly H3. This is influenza A H3. And we often take indications about the efficacy of vaccines from what happened in the Southern Hemisphere because they see the viruses first. And very good news for us is that it looks like it was been a relatively good match, again, for protecting people from the most severe infections, so reducing the risk of hospitalization by about 50%. So again, we just urge everyone to get their patients who are eligible to be vaccinated as soon as possible, because we are, again, starting to see influenza. And then the third part of our triple epidemic, of course, is SARS-CoV-2. And I'm sure everyone is reading the news with the same dismay that all of us on the panel are, meaning that we are seeing new Omicron variants. We are facing the winter months where we are more indoors, and there's a concern with emerging evidence that there may be an ability of these variants to have some escape from our pre-existing immunity. But so far, the rates of SARS-CoV-2, while increasing, are nowhere near the numbers of RSV that we're seeing. But I'd love to hear from my colleagues what they want to add to that.
I think too, Lisa, you know, all great points that as we relax our vigilance with the mask and the hand hygiene and everyone needs to go back to school and back to their activities. We just have to remind each other, don't go to school sick, you know, and remind everybody to wash their hands. We are definitely seeing an increased severity of regular like rhinovirus and enterovirus in the hospital, you know, where those in the past, we would just find it and be like, oh, it's just there. Everyone has it and the patient was relatively asymptomatic, but now they're getting super sick and being admitted. Some of our patients are the ones who are immune compromised. And as you were mentioning too, it feels like because there's so much problems with vaccine hesitancy and also concern about the COVID vaccine and boostering. I know many of my friends, colleagues, and some of my older adolescent patients have been deferring their influenza vaccine. So I think it's the 1st of November, it's time. It will, if you get it now, it will last you through the season. And also getting your boosters for the COVID is very important. And there are other things that we have also. Dr. Zucker, I know, is doing a clinical trial for some of the treatments. So he might talk a little bit about that.
Sure. We do have a clinical trial for individuals testing positive for coronavirus or COVID-19. And so we do have a clinical trial of Paxlovid in pediatric patients under the age where it's approved that they can enroll if they have that and are interested, because we are seeing children who get really sick, not just from RSV and enterovirus and all the other seasonal viruses, but still from COVID-19 as well. Yeah.
So that's all great. So a lot of respiratory illness, but thank you for addressing some of the tools that we already have to prevent and or treat. We already have 2 questions, and I'll just, maybe we can address those live. So how old are the kids who are getting really affected by RSV? Are they in that younger age group, or are some of the older kids getting severely ill, is the first question. I don't know.
Yeah, I can certainly dive right in. I mean, we have our local kind of anecdotal data, but also when you look at the CDC in terms of rates of hospitalization for patients who are coming in with RSV, it still is predominantly that 2 and under group that we're seeing that has the higher rates. But certainly there are children across the age spectrum that are getting seriously ill with RSV and requiring hospitalization.
Great, thanks. And then the other question was just, you touched on a little bit, but is this bivalent vaccine showing good efficacy against the current circulating COVID strains? I know you, so I see Natalie looking to answer that.
I think we don't really know yet, but we're hoping. The data for children look good for vaccination. And remember, people have to remember, you know, the idea behind vaccines is not to say you're never going to get COVID, but that you're not going to get severe disease. You're not going to die. That's a huge, you know, bonus. And, you know, children are in households with older adults and they want to see their grandparents, and we're coming into the holiday season where everyone's going to be gathered together. So you can't have like a better time than right now. Do both at the same time. That's what I did. So, you know, right before Thanksgiving and other holidays, it's the perfect time to like go ahead, boost yourself up and protect those around you as well as yourself from severe disease.
Absolutely.
Can we just, before we leave sort of these sweeping epidemiologic, big issues that we're all facing, I just wanted to talk a tiny little bit about EVD68. Natalie mentioned this marked increase in rhinovirus, enterovirus, and we just recently got some data from the New York State Health Department from September and October in terms of how much EVD68 we were seeing among children hospitalized with rhinoenterovirus. So let me just take a pause here and say that every several years, we see a surge in EVD68. And the assays that we use to make these diagnoses that the audience is probably familiar with, which are these multiplex polymerase chain reaction PCR assays, don't distinguish between rhinovirus and enterovirus. They're just too closely related. So all we know as clinicians, as Natalie said, was we'll see that the patients have rhino-entero. But we sent, at the health department's request, a lot of the samples to the laboratory in order to do sequencing to help us understand if EVD68 was circulating. And the reason we deeply care is because a very small proportion of children that have EVD68 can get acute flaccid myelitis. And it's very, very important for people to recognize that. The good news is it looks like we saw our surge in September. We had a huge surge of EVD68, fully 50% of the enteroviral samples were positive for EVD68, but that dramatically decreased in October at about halved. So this is not specific to our hospital. It was pooled data from all of New York State, but it just teaches us once again that everything that we're doing now, as Natalie mentioned, to be back in the world and trying to get things as back to normal as possible, do have some unfortunate risks associated with them. So I just want the audience to recognize this possible, very rare complication of EVD68 because it looks just like polio. And we've been hearing about the wastewater positive for polio. And so I just wanted to alert the audience to that.
And can I ask a little bit about the timing? Because I know it's after the phlasmodialis, but do we know more as years go on about how many weeks after?
Yeah, so it's a thank you. I was just going to mention that, Jennifer. Thank you so much. So it's not part of the acute picture, which is usually a respiratory tract infection. It's a post-infectious presentation that happens about 2 to 4 weeks after the acute viral respiratory illness.
Okay, great. Thank you.
The other thing I'll just add, and as we're talking about EBD 68, is also just a reminder that it can present with severe respiratory symptoms too. And so I think it's certainly come to the forefront because of the acute phlasmodialis, but also even in 2014, when we saw that uptick in EBD 68 as well, it was also those acute respiratory symptoms where children were coming in with severe respiratory distress and requiring hospitalization and support that brought it to attention as well. So keeping that on your radar as well.
Great. Thanks for that. Just because a lot of questions are coming in, maybe we should address some of them as they're coming in. How would a child be enrolled in the clinical trial for Paxlovid is the question. And is it only inpatients or only patients that come directly through our emergency room?
It's actually only outpatients, and they don't have to come through our emergency room at all. I'll post the link in a couple of minutes once I grab it from my email so that people can find it.
Okay, great. And someone's asking, do you think Paxlovid will ultimately, I mean, I guess we don't really know the answer, be recommended for anyone with COVID, or will it be just for people who are high risk, or is that what you're really trying to figure out?
I think most likely so Tamiflu we offer to everyone, but when you really look at it, it's the groups that are prioritized for Tamiflu are really the groups at risk for progressive disease or serious disease, although we do offer it to everyone. I think most likely Paxlovid is going to be for individuals at higher risk of progression to severe disease and not necessarily for everyone, especially because for a lot of people, the disease can be mild, but for those who are at higher risk, it can be really severe.
Okay, great. Which brings me to another question I had. What other tools, and maybe Dr. Saiman wants to answer this or anybody on the panel, what other than Tamiflu, what is new in 2022 for treating the flu, besides this version of the flu vaccine, which thank you for pointing out that it sounds like it's going to work this year.
At least for H3. That's
yeah, well, that's good. What about for treatment?
So there is a new kid on the block, an antiviral that is, Jason mentioned Tamiflu, oseltamivir, which we have a lot of experience with, and we use in all age groups. We use in inpatients, outpatients, patients with comorbidities, even pregnant people who are at increased risk of severe influenza. The newest drug is baloxavir, which is approved, but it has a more limited approval range so far. It's only one dose, so that's a huge advantage. Just like oseltamivir, you want to use it quickly within the first 48 hours of illness. That's when these drugs seem to be their most effective. And it's available for people who are 5 years of age and older, but there are some restrictions in the 5 to less than 12-year-olds. For example, you can't have any chronic medical conditions, and those are the people that tend to get into the most trouble, as Jason alluded to. For people who are 12 and older, it's pretty much anyone is eligible. And just like all of these agents, we expect that things will get broadened as there's more information coming out with other clinical trials. But just to be complete, this agent is not recommended for pregnant people, breastfeeding people, people with complicated progressive illness. So frankly, Jennifer, I'm not so sure how much of a new tool in our toolbox it'll be, with the obvious advantage that it's a single dose, which really improves compliance. It does, you have similar like GI, people do experience some GI discomfort with it, but you wouldn't know that until they had taken the agent, unlike Tamiflu, where people might stop it because they're uncomfortable from the agent.
Great. So we've sort of covered some older vaccines, and since we did a newer medication, I thought maybe we could just talk about vaccines or preventive measures for RSV that might be out there that are newer that we can't use yet, but are in the future?
Yeah. So I can start again, Jen. This is actually a good week for the RSV story. So the audience is probably aware we do not have a vaccine for RSV. There's a very bitter, difficult history with RSV vaccinations, where a formalin fixed vaccine was actually associated with more severe illness in the children that got RSV. So it was terrible, up to and including death. So there's been enormous reluctance to move forward with an RSV vaccine platform. So that's why we have an RSV monoclonal antibody, and people in the audience are familiar with Synagis, and palivizumab is its non-brand name. And but the problem with Synagis is it's been limited to very high-risk children, very preterm children with underlying comorbidities like cardiac, pulmonary, and neurologic comorbidities. And it's quite cumbersome to give because you basically give it for 5 months. It is very effective at preventing hospitalization. So a big theme that we're developing as a panel here is that so many of the tools in our toolbox prevent severe illness. So the really exciting news is that there's 2 or 3 companies working on a longer acting monoclonal that is only needed to be given once or twice and will protect high-risk infants through the whole season. And the goal of these is also to broaden the population. So to be able to use it in late preterm babies and to be able to use it in otherwise healthy term infants. Because when you look at the epidemiology of who's getting hospitalized, those are the babies who are, except for this year when we're seeing such different epidemiology, those are the babies that are getting hospitalized. So that's very exciting. As you mentioned, we don't have that tool in our toolbox yet. That's being filed with the FDA for approval. But hot off the press, another important strategy to prevent RSV vaccine in children is actually vaccinating pregnant women. So this is such a wonderful strategy, in my personal opinion, because what we're saying is that if you vaccinate the mother, then the antibodies will be passed to the baby via the placenta, via breast milk, and protect the baby at their most vulnerable time. And the study was just stopped today before they had reached their full sample size because they reached their efficacy endpoints, again, at preventing both hospitalization and medically attendant lower respiratory tract infections. So there's a lot of excitement about both of those strategies because they would totally broaden our ability to protect a much, much larger number of very young infants from RSV. So I'm in a good mood about that today.
So interesting too. I mean, just
Yeah,
the whole process and all these different tools that we'll have in the future.
Mm-hmm.
So I'm going to turn because we still do have a few questions from the audience. So one comes that many parents feel they don't want to give the original COVID vaccine anymore now that the bivalent is available. And any of you have any thoughts on that?
Yeah, I can start on that one actually. So, we don't actually know that the bivalent vaccine is better than just the regular vaccine. The most recent study we have actually, disappointingly in some ways, showed that the bivalent vaccine was equivalent to the current vaccines. And so while we know that both of these vaccines will definitely reduce our risk of severe illness, we actually don't have any evidence that the new one is better. It's probably better to have a broader range of antibodies produced from different vaccines, but that wasn't what was shown in the clinical trial. So I got my bivalent vaccine and would do it again, but certainly getting any vaccine is beneficial. And certainly getting sort of the original vaccine will help as well, even with the current circulating COVID strains.
And just following up, another question related to the vaccine is, do you know sort of nationwide statistics on the COVID vaccine status of children being admitted to the hospital and/or influenza vaccine status of children being admitted to the hospital, or is that too hard to parse out? Or anecdotally? anybody know?
I was just going to say, I don't have numbers. I was going to actually piggyback off of Jason's comments so really quickly, because a question that has come up in regards to kind of the original COVID vaccine and then the bivalent is, we all early on got the 2-shot series and then an additional booster. And now with the bivalent, getting the bivalent. And for children, the original 2-shot series didn't roll out until later. And so you certainly can give that 2-shot series without that additional booster that most of us got and get the bivalent instead. So getting the 2-dose series of the original and then the bivalent is completely acceptable and something that should be talked about with parents as well.
Great. And then sort of following up on preventive measures, someone is asking, with the expansion of, or the sort of unpredictable expansion that we don't even know how long the RSV season's going, any word on treatment with Synagis for those babies who are on Synagis and how long that's going to go for?
Yeah, well, it's a great point. And the American Academy of Pediatrics has been really on top of this. When we had that very strange interseasonal RSV last year, they actually recommended starting the Synagis doses earlier and approve them for longer. But it is worth noting that there are data that suggests that even the rate of eligible infants getting Synagis has declined. And it may have something to do with how cumbersome the recommendations are to give it, and it may be how cumbersome it is actually to deliver it. But again, to people in the audience who have eligible infants in their practices, we really need to make sure that they're getting Synagis now. This is a very, very difficult year. And the other thing to mention, of course, is that COVID vaccination rates in children are way behind the COVID vaccination rates in adults. So while I don't have data on the relative proportion of hospitalized children who are not vaccinated, we know that children are not being vaccinated at the same rate. So this is another opportunity to help protect our children.
Excellent. And someone just had a question about the RSV vaccine during pregnancy. Do you know when they were giving that vaccine in the study? What trimester?
I'm pretty sure it was at the end of the second trimester, but I don't quote me on that. I can look it up.
Sure.
Because you want, like most antibodies go across the placenta in the 3rd trimester. So you want to get that advantage. And obviously these were women that were delivering full-term babies, but I can see if I can look it up while we're talking.
And
I
then
do want to say, just like anecdotally, in terms of your question before, right now, the kids admitted with COVID, many of them have been vaccinated, but they're immune compromised or have some other respiratory, or they're co-infected with the rhino-entero and COVID. So that, or COVID and RSV, which is making it more complicated. The other thing, just to say, to Lisa's point, that might be helpful in the pediatric practices. I know sometimes the electronic medical records are a bit unwieldy, but creating a checklist in your practice or something that's easily drop downable for those young infants when they enter your practice to understand if they are eligible for the Synagis would be something that would be a super easy solution that can help you and the families in terms of getting them access, because I know sometimes the appointments are super fast and you have a lot of things going on. It might not be something that's directly thought of, so it could be helpful.
that's a great point. That's really a good tip, I think. Someone's asking just about Paxlovid rebound in children and whether you're seeing that in children and adolescents, the way it's reported in the media for, and generally anecdotally for adults as well.
I would say with the most recent strains, definitely, I have a lot of experience within adolescents, and the ones who've taken Paxlovid, or even now without Paxlovid, will sometimes have a recurrence of symptoms a couple of days after they think they're better. So it's certainly something you want to keep an eye on. It's something you want to watch and make sure that if you have recurrent symptoms, you retest yourself. the current CDC recommendations are you can leave isolation after 5 days, but there's always a benefit in testing yourself and also keeping a mask on for longer after a recent infection to try to reduce spread to other people, especially if you do have rebound where you have recurrent symptoms and recurrent viral rebound.
Great, thank you. And I just wanted to talk about the co-infection just a little more, because I think people will be interested, Natalie. When kids are co-infected, I mean, is there a way to parse out, was it one infection and then it's just still testing positive and it's really, one etiology for the acute illness? Or do you think it's really like a storm, like both infections, or you really don't know?
So hard to say. Both viruses cause significant inflammatory disease in the lungs, and how to determine which one is which. Lucky for us that, sometimes steroids actually are the treatment, especially if somebody is significantly or seriously ill, to control the inflammation. One of our most recent patients actually had COVID 4 or 5 months ago, and then represented now with COVID, but she wasn't immune compromised, but she had both viruses at the same time. So if we can help and we can treat, with remdesivir in the hospital and steroids, we do, but it is really, really impossible to parse out which one it is. And I think that's a really hard thing too for the pediatricians. Like, many offices don't have these tests available to them, or, there isn't like a rapid point of care except for RSV and influenza, which I think should really be used in the offices now. A lot of parents want to know like what the viruses are. The testing is out there. Hopefully the practices have a way of sending it. It is very helpful to know what virus it is, because for the COVID, if it's mild, for example, we can give the treatment as we're talking about. But I think in terms of like transmission and control and epidemiology, it is important to know what virus they have. But of course, there's the issues of insurance and how do you send it out and all that have to be worked out. But we've been gearing that up over the last 2 years. That hopefully most practices have come to a decision about what they're going to do with that in terms of testing. As a general pediatrician, do you guys have it in your office?
Yeah, I think a lot of people have different variants of point of care tests that they can do from different companies. And they're certainly, having just been to the AAP conference in Anaheim, they're certainly these kind of tests are being highly promoted to office practices as well. So, yeah, so thank you for that. I think we've answered, I'm just looking and I apologize, but I think if we have not, but we've answered many of the questions live, and we will continue at the end to try to answer them if we don't. But I wanted to move on to monkeypox virus, or MPV, because we have really the frontline expert, I would argue, in the nation on MPV, and that is Dr. Jason Zucker, who some of you may have heard him speak about it at various grand rounds and podcasts, etc. But we're really lucky to have him tonight. And I know that, the surge has lessened, but it has not gone away. And I just hope he will just talk to us a little bit about monkeypox, about diagnosis in children and adolescents, and about MPV and how we talk about that with perhaps high-risk adolescents and who should get vaccinated for that or not. So with that, I give you Dr. Zucker, who really is the expert, I would argue, on this illness.
Well, thank you very much for that very kind introduction. Thinking about human monkeypox virus, or MPV, in children and adolescents, I think there's really two things that as pediatricians we have to think about that make it challenging. There have been about 28,500 cases in the US, and the vast majority has been reported have been gay, bisexual, and men who have sex with men. However, there's a large number of these cases that are occurring in other groups. Almost 800 cases have occurred in women so far. We talk about in pediatrics 2 different groups of people. We have young children, and so far we've not seen a large amount of infection in young children, only about 50 cases in those under 16. However, in pediatricians, we don't stop at age 16. We often go up to age 21 and 23, and there have been almost 600 cases amongst those age 16 to 20, which tend to be the ones that are more acquired through sexual activity. And so you have the sort of household exposures in the younger kids, and then you have these sexual activity exposures in the older kids. What I always recommend to the college health group when we talk to them, as well as other providers, is talking to adolescents about monkeypox virus is really the same way we should talk about any sexual health activity, sex, STIs, HIV, and anything else. It's about being open. It's about talking to your sexual partners. It's about harm reduction methods like condoms or frequent testing. And it's most importantly about avoiding shame and stigma, so that if patients have a lesion or have something that looks wrong, they're not hesitant to come to you and ask for testing. I think that's really the most important thing, is that these things happen. And what we can do is provide open and caring environment for patients to be comfortable to come to.
And actually, Jason, to that point, since it's so much in the news, it might be a great tool for pediatricians to say, hey, like, have you seen the news? There's a vaccine that's out there for this monkeypox thing. And, well, everyone's having sex, let's talk about it. So it's a great way. It's almost like a great tool to sort of open up that discussion about sexual health and sexual activity.
Absolutely.
And what about in children and diagnosis in children versus
so the diagnosis
I don't know if go.
Yeah, the diagnosis is always going to be the same way. It's swabs of skin lesions. So this disease is classically defined by skin lesions, and I can pull up a couple pictures if we would like, and we can.
And I just, for the benefit of the YouTube audience, I'm just going to say that these next photos will contain photos and pictures that many people might find these images disturbing, and they're sensitive images.
That's right. And we'll start initially with just some of the sort of less disturbing images. And these are really the skin findings that we see in monkeypox virus. So this is the real classic presentation, starting with an incubation period of 5 to 21 days after exposure, meaning that it can be up to 21 days after you're exposed before you have any symptoms at all. It then starts with prodromal symptoms, which are really a lot like the viral symptoms we just talked about in the previous lecture, or the previous part of this: fevers, lymphadenopathy, muscle aches, vague symptoms, before going into an anathem or oral lesions, macules, which are flat lesions, papules, which are small lesions that look like acne and are very easy to confuse with acne. These progress into fluid-filled vesicles, and then eventually the more classic pustule. And you have this sort of classic pustule that was really the image, similar to the image we saw when this first started. But then you also have these umbilicated pustules, which are also very classic for this disease. After that point, it scabs over. And one of the really interesting and unique things about this virus is actually you're still contagious, and that these scabs contain very high levels of virus and can still be passed on to others until the scabs fall off and there's new skin underneath. And so we actually ask patients to isolate for a much longer time for this disease than we do for many others, because we actually have to wait for new skin to form before they're not contagious anymore. And so the way we test for this disease is actually a swabbing any of these types of lesions. These lesions, as I said before, have very high viral loads. You don't have to unroof them to get a good swab. You really just need to swab semi-vigorously over the top of them and then send it to your local lab for PCR testing for the virus. And if it's there, you'll find it.
And just I think this came up before, but you were during the height of the Coxsackie season. What kind of questions can we ask? It's usually an easy diagnosis for general pediatricians, but with monkeypox in the mix, what questions do you suggest asking parents if we have some questions about a not straightforward case of Coxsackie?
Yeah, I think it really comes down to your pretest probability. As I said, in young children who are not sexually active, there have only been 50 cases in the United States out of 28,000. almost all of those cases have been associated with a known contact, a caregiver, a parent, somebody close who takes care of the patient. And so I think what we're really trying to do is assess what epidemiological risk the patient has. And if they don't have any epidemiological risk, it's pretty unlikely to be monkeypox virus. What I also tell people all the time is, you do get false positives to PCRs. And so if you run a test in a low probability patient, you're more likely going to have a false positive than a true positive. And so don't send the test in a patient who has no known epidemiological risk factors. Send the enterovirus test first. If the patient doesn't improve, if that test doesn't come back positive, you can always have them come back and test later. But most of the time, you're not going to need to, because again, in people who don't have known epidemiological links, it would be exceptionally rare to find this virus.
Great, thanks for that.
Mhm.
So I think we'll turn now to some more questions, and we'll start with a question that relates to monkeypox and how young of an adolescent have they given, and you may have addressed this already, the MPV vaccine to?
Yeah, so the MPV vaccine was approved by the FDA for human monkeypox virus for individuals down to age 18. At the start of this outbreak, they modified that with an emergency use authorization down to any age. And I know it's been given down to several months of age. I don't know exactly what the lowest is, but it's been given down to several months safely.
Great, thanks for that.
Mhm.
Any other comments on MPV from anybody else? But I think that's really, really helpful to see the photos and to talk about how we will, I think, as a group of pediatric adolescent healthcare providers, be talking about this probably for our lifetimes, it seems like.
I just have one more thought. Sorry about this.
Yeah,
One more thought is just, we talked a little bit about vaccine. You just mentioned it, but the vaccine can be used for prevention, but it can also be used for post-exposure prophylaxis.
Oh, great.
And so if you do have somebody who's exposed, you can arrange for them to get vaccinated. And like we said, this is a non-replicating vaccine, meaning it's safe below age 12 months. So for people who are exposed, if you do have a patient who's exposed, it's great to get them vaccinated early. The earlier you vaccinate them, the better. Within 4 days, the hope is it prevents disease altogether. But within 14 days, you can prevent more severe illness.
Great, good information. Now I'll just turn back to some questions that are coming up about Paxlovid rebound again. And somebody's just asking, is it that different from the same pattern that's seen in untreated COVID infection? And I don't know if anyone wants to take that question. Or are we seeing that kind of rebound?
I haven't really seen
Yes.
that much rebound in untreated COVID. I think what more we're seeing is the long COVID, like the symptoms maybe not resolving as much or taking some time. Even those who had very mild illness, sometimes they have fatigue for an extended period of time. I think that has been very difficult for some parents, and there's a lot of mental health issues along with the COVID that have, I think, contributed to that fatigue that we're seeing in a lot of our adolescents. Would you agree, Cece?
Yeah, I completely agree. I think the other thought that comes to mind is certainly when we talk about kind of this Paxlovid rebound, we've been focusing on the symptomatic rebound, but there are those cases where patients are asymptomatic and they test positive again shortly after having a negative test. And certainly that has been seen in untreated COVID, particularly in our immunocompromised population, where they can have persistent shedding. And so they may have intermittent shedding of what is presumed to be non-viable virus. So not something that's going to transmit necessarily, but you can see that kind of rebound in terms of having a repeat positive after having a negative test in patients.
And again, what are you recommending for that? Let's say somebody, are you recommending in terms of isolation and or treatment if they've never been treated? with Paxlovid? Cece, I don't know if you
I
want
think,
to.
I think it's really going to depend on the patient's presentation. So if you're talking about an asymptomatic patient who did a repeat COVID test for whatever reason, which we aren't recommending those repeat COVID tests, but had a repeat positive and they were asymptomatic, then there would be nothing to do for that patient. If you had a patient that had an improvement in their symptoms and now we're developing new symptoms, I think doing a bit deeper dive in terms of the epidemiology, who they have been exposed to, what their symptoms were and what their risk factors were, again, for progression to severe disease, would help inform your decision about what best next steps would be.
And as you know, like as you're sort of mentioning, Cece, we are seeing people who are getting COVID infection in shorter time frame than 3 months. We're seeing 2 months, for example, where they're getting another infection. So it's not unheard of.
To see a new infection in that short time period with a new strain. Okay.
So you've seen this as well?
I'm just, I'm not sure. I'm asking the epidemiologists to confirm that.
Definitely
So-
been reported, Natalie, that it can be as short as 30 days after the other infection. And I'll just really add that these are people that are symptomatic, that's with detectable virus. And that you can look at the what we call the cycle threshold to be a surrogate for viral load, and they have a low cycle threshold, which means the PCR test turned over quickly. So it's a higher viral load, but it definitely is something that has been associated with these new Omicron variants we were mentioning earlier.
I'm just looking at some of the other questions. One is on also on MPV, a monkeypox. How long the isolation period would be for a child with MPV who is not vaccinated. So I'm assuming that means from somebody who was exposed and
Right.
not vaccinated.
So after exposure, there's not currently a recommendation that people have to be isolated. Part of that is because this is primarily transmitted through close personal contact and skin to skin contact. And so generally what we recommend for people who may have been exposed is that they examine themselves, or in this case, a parent examines the child looking for lesions. But if they don't see any lesions, there's really no reason to isolate. If they see lesions, the recommendation would be to go to their pediatrician right away for testing. And they would just watch them. Vaccination can, again, help prevent disease or prevent severity of disease. And so we always do recommend it, but it doesn't change or modify the need for isolation, or the lack of need for isolation, I should say.
Excellent, clear answer. Thank you so much.
But it's
I asked
long,
Jason-
right?
Yeah, it can be super long.
It's 21 days.
Yeah, or until you get new skin, which for some people.
Oh, if they're infected, yes.
Yeah. Jason, could you just, one thing that I always gets people confused, I think a little bit, is like infectivity, if people have the prodrome. Could you just address that?
Yeah, that's a challenging part because you are technically infectious during the prodromal period. You don't have skin lesions, but you likely have lesions in your mouth, and saliva and other oral fluids can transmit the virus. And so kissing and other mouth to skin or mouth to mouth contact could transmit the virus. So we do recommend for individuals who are at elevated risk of infection, if they have a prodrome, they really should consider either isolating or not having any close contact with others for 5 days. If the rash doesn't develop within 5 days, then it's unlikely to be MPV, because in general, the rash will develop within 5 days of the prodrome.
So in other words, the prodrome is so non-specific that it could be from other things. And
That's right.
So, yeah.
That's right. So again, it goes back to pretest probability. If you're in a group of people where you've had an exposure or known contacts, then the recommendation is either to isolate, or if you can't isolate because you have to go to work, just don't have skin to skin contact, and then check yourself while looking for this.
But all you can do is test a skin lesion. So those individuals just have to
That's
wait.
right.
Yeah.
In the United States, in other countries, they have testing of other compartments.
I think too, what's important, and this happened during COVID, is that pediatricians should not be afraid of bringing these patients into the office. You know, we have been through COVID. We know what we have to do in terms of infection control and prevention. Like the healthcare and evaluating these patients in person is absolutely critical. You can put on a gown, you can close the door. You're not going to get it if you look in their mouth. Like you should wear your, goggles if you have them, but you're not having that extended exposure that you can't send the swab and do the testing for it. We need these children to be seen.
I think that's a great point is, there's been extremely limited healthcare worker infections. The vast majority have actually been needle exposures where they tried to unroof a lesion and then stuck themselves with a needle, which, as we discussed earlier, these lesions have a lot of virus. So if you stick the needle directly into yourself, and then they get the lesions at the site of that inoculation. There's a great paper from Colorado that I know Lisa and I both looked at that really looked at, patients that they didn't know had monkeypox virus and they didn't wear proper PPE and there were no infections, even the highest risk exposures. So, not to say don't wear your PPE, you should always wear the proper PPE, but the risk of healthcare worker acquisition is exceptionally low and shouldn't stop you from seeing these patients.
And we really have so much personal experience here, right, at NewYork-Presbyterian Hospital. So many healthcare workers have taken care of so many patients while they're infectious. And we do have a very good handle on what Jason is alluding to. People are just not getting infected. And I think it's just like the understanding that it's a sexually transmitted infection and putting it into that context is really, really helpful. The worst thing that happened during the worst part of the pandemic were that people weren't getting the health care they needed. So we don't want to go back to that time.
Great. So with that, and in the interest of time, I'm going to say we've covered quite a lot from our Columbia Children's Health Pediatric Infectious Disease experts tonight, from the triple-demic to the immunity gap. We've covered some preventive and treatment therapies that are current and then on the horizon, and MPV or monkeypox virus. And I'm just going to ask each panelist to give a quick pearl or maybe think of one thing they want to say, and they might all be the same thing. And I'll start with Cece to close this out.
Thank you. So thank you for having us. And I really appreciated this discussion with my colleagues. I think my one pearl is the basics. An ounce of prevention is worth a pound of cure. So I can't stress enough the importance of vaccination for COVID vaccination. So again, encouraging your parents and your patients to have their children vaccinated, either the primary series if they haven't received that, or the bivalent booster if they're due for that. And similarly, the flu vaccine, as Natalie said earlier, this is like your optimal time to get vaccinated against flu. So please, vaccination is critically important.
Great. And Natalie, going around the screen, any last pearl?
Well, I love sexual health. So I'm going to say, let's use this sort of epidemic or pandemic or whatever's happening, we want to call it, of monkeypox to stimulate our pediatricians' minds and our offices to do more of discussion around sexual health. And, there's so many things that we know can be passed by all sorts of sexual activity. And then there's lots of prevention as well. So that would be the thing that I would like people to sort of take from this conversation.
Excellent. And Lisa, Dr. Saiman?
I love what Cece and Natalie said, and I can't wait to hear what Jason said, but I'm going to take a different tact because I'm a hospital epidemiologist, and I'm going to use Cece's phrase, get back to the basics, but I think it would be really useful for the audience to go back to their colleagues, their team members in their offices, and just revisit basic infection prevention and control strategies. We really struggled during the worst of the pandemic with absent staff members. And we want to keep all of you and all of your team members as healthy as possible. So just reviewing the basics, answering questions that people may have that they're really scared about. Hopefully doing away with some of the misunderstandings and misconceptions. I think that could be incredibly useful.
Great. And then we'll finish with a pearl from Dr. Zucker, who's in the center of my screen. So left him for last.
Dr. Dew totally stole what I was going to say, so I'm trying to come up with something new on the fly, and she knows it because she's laughing at me. I think, going back to sort of what everyone said, right now my focus has been MPV, and just like with any disease, it starts with vaccination. It starts with testing for people who have symptoms and making sure you get tested, whether that's for a sexually transmitted infection, for monkeypox virus, or for COVID. If you're having symptoms, get tested. And then do what you need to do, whether that's to get treatment if you're somebody who's at elevated risk for severe disease, or whether that's staying home to not spread it to others, or whether that's wearing a mask when you go out afterwards. Do what you need to do to help us stop all of these outbreaks.
Great. And I think that was, that we actually, I'm looking, more and more questions kept coming in, and I apologize that we couldn't get to all of them. And I really appreciate all of the audience engagement with our great panel. And there are certainly, and I'm looking at them, some really excellent questions here. But I think we really covered a lot tonight. And with that, I will let it go. You can always reach out to us at Columbia Children's Health with these questions, and we can try, we do know how to reach some of you. We can try to answer some of these offline as well in the Q&A and or by email. Because they're all really excellent, and I'm sure some of us have even more questions that are in the Q&A. So with that, I will conclude the webinar. Thank you so much for participating in our Columbia Children's Health webinar. We will be back again in 2023 with more topics. And for those of you who'd like to rewatch or like to share this with your colleagues, again, it will be on the Columbia Children's Health YouTube channel as of tomorrow. So thanks so much and good evening.